Leishmania tropica. So for Leishmaniasis, parasites is a vector-borne disease that is transmitted by sandflies and caused by obligated intracellular protozoa of the genus Leishmania. Human infection is caused by about 21 of 30 species that infect mammals. L. tropica or Leishmania tropica are the causative agents of what is referred to as Old World cutaneous leishmaniasis, or also known as Oriental sore, Baghdad, or dilly boil. Distribution of Leishmania tropica is common in the eastern Mediterranean Middle East, North India, Afghanistan, and Northeast and South Africa. It is an endemic in the Middle East, Africa, and India. In patients infected by L. tropica, dry papular or dry ulcerative types are often observed, usually on the face and other exposed area. And it is transmitted by the phlebotomous sandfly and primarily attacks the human lymphoid tissue of the skin. The sandflies inhibits where L. tropica prefers warmer climates. The parasites can be found in urban, rural, and semi-desert areas with suitable conditions for sandfly breeding, such as rocky, vegetated, and humid environment. So the pathogenesis of Leishmaniasis or L. tropica starts with sandflies or the phlebotomous sandflies. So the life cycle of Leishmania tropica starts or begins when an infected female sandfly bites a human, injecting the Leishmania tropica parasite into the person's skin. And the promastigotes are phagocytized by macrophages, other types of mononuclear phagocytic cells, and the promastigotes transform into mastigotes, and then the mastigotes multiply in cells, or um, the the macrophages, where the amastigote to the promastigote or the transformed promastigote inhibits will rupture, and then it will goes to other mononuclear phagocytic cells, and then it will stay on the body, and then another sandfly takes a blood meal and ingests the macrophages infected with mastigotes, and then ingestions of parasitized cell, a mastigote transform into promastigote stage in the gut of the sandfly and divide in the gut and migrate to proboscis. And then the sandfly takes the blood meal and injects promastigote stage into the skin. And then where the Leishmania tropica will start to show signs, manifest as skin lesions, and the disease usually presents with one or multiple painless ulcers, which may be surrounded by inflamed raised border and can be found on exposed areas of the body such as the face, arms, and legs. Ulcerative form, indisseminated form, diffused form, atypical form. Immunity and morphology. The immunological spectrum observed in patients with leishmaniasis ranges from individuals with a strong T-cell response characterized by delayed type hypersensitivity and high levels of interferon E to individuals who lack a DTH response may have high levels of antibodies. The morphology of Leishmania tropica is between promastigote and a mastigote, whereas the promastigote has kinetoplast and the amastigote has an axoneme. Diagnosis includes microscopic examination, culturing specimen, serological test, and tissue biopsy specimen to determine if it is really a Leishmania tropica or it came from L. tropica. Prevention and control. Controlling the L. tropica includes controlling insect vector, environmental management, personal protection like using netting, window screens, protective clothing, and insect repellents. And there are also vaccinations that has been developed against L. tropica and is currently undergoing clinical trials. Treatments includes um, sodium estibogluconate, which works by disrupting the parasite cellular processes, ultimately leading to death. Steroids with applicants of heat to the infected lesion or paramomycin ointment that can be administered orally or intramuscularly, and meglumine, antimonite, pentamidine, and other oral drugs that can be used to kill the parasite. So that's all about Leishmania tropica.